Thank you, Professor Hurt. We'll move on to the next speaker. It's with great pleasure I introduce Professor Dirk van Raemdonck, who's a professor in the University of Leuven, who's also the ex-president of the ESTS and a good friend.
Thank you. Good afternoon. First of all, I would like to thank Dr. Raemdonck for the invitation and the company, Belgium, for bringing me over to give this talk on lung volume reduction surgery and transplantation. We have not heard about transplantation in all the algorithms, certainly in the first speaker. So I will briefly talk on surgical lung volume reduction surgery, followed by transplantation, and then I will put the two surgical procedures into perspective. So let's start with lung volume reduction surgery. You have already heard a little bit about it. It was the concept was originally described by Otto Brentingen in 1959 already, and he did 33 patients, resected most of the useless areas, but also added denervation. He had a high mortality at that time, 18%, and 75% of the patients had subjective improvement. However, no objective data were recorded. It was Joel Cooper who was brought the work of Brentingen to the attention by Jean Deslauriers, and then he also had his observation in patients who had single lung transplantation for emphysema. And as you can see here in this patient who received the right single lung transplant, the chest cavity has nicely adapted itself towards the volume of the right donor lung. So we are talking about these patients with heterogeneous emphysema, mainly in the upper lobe. And we are talking about this procedure, resecting the periphery of the lungs with the most destroyed areas. And this is the picture that you can see after lung volume reduction surgery, reducing the lung in volume of about 30%. As already said, it can be done through a median sternotomy, but however, most groups nowadays are doing this procedure thoracoscopically. Some groups have described a non-resectional technique using a plicator in order to reduce the air leak after the operation. And this will result in the physiological changes that are listed here on this slide. So you remove the dead space, you relieve the alveolar compression, there is improved elastic recoil, and you are restoring the tethering effects of the bronchi. And most importantly, the chest wall motions will improve as a result of better diaphragmatic excursion. Pictures you've already seen before and after lung volume reduction surgery with elevation of the diaphragm and improved breathing mechanics, and also a reduction in the diameter anterior-posterior after this volume reduction surgery, and then another picture on CT scan. This is the series from Joel Cooper in St. Louis. As you can see, very good survival results in well-selected patients with survival up to 5 years of nearly 68%. However, if you look at the morbidity and the mortality in this series, you can appreciate that there is certainly morbidity. 55% of the patients had problems, mainly prolonged air leaks, pneumonia, reintubation, tracheostomy, and so on. And 5% of the patients did not survive after the procedure. You've already seen this publication in 2001 that killed, in fact, the referral of these patients for volume reduction surgery, because patients with a low FEV1 below 20%, a low diffusion capacity below 20%, or homogeneous emphysema had a mortality of nearly 16%, and these patients should go directly to transplantation or non-surgical options. You've also seen the results of the NET trial already, categorizing the patients into 4 groups. those with upper lobe and those with lower lobe predominance, and those with low baseline exercise capacity after rehabilitation or high exercise capacity. The results were further analyzed by, of course, the NET group, and the first author of this paper, Keith Neuheim, has come up with this algorithm that, in fact, all the patients listed here in green, they qualify for lung volume reduction surgery, not only because of the benefit in survival, but also for the benefit in exercise capacity and in the dyspnea score. After the NET trial, not much publications came out on lung volume reduction surgery, but this paper from the Columbia group in New York has shown that it can now be done with much less morbidity and certainly very good survival, showing here 98% survival after 3 years and 95% survival after 5 years. The group in Rome, led by Eugenio Pompeo, has now developed to a less invasive technique, the so-called awake non-resectional lung volume reduction surgery, and he has shown in this recent publication that the results, in fact, are similar in terms of survival, in terms of freedom from contralateral treatment, and also in terms of pulmonary function, exercise capacity, and dyspnea score, so between non-resectional versus resectional. However, the patients who had non-resectional surgery had a much shorter hospital stay because there was less air leak, prolonged air leak after the operation. As already said, not much patients are referred now for lung volume reduction. This is a study looking at patients in the Society of Thoracic Surgeons database, and across the whole US you can see that less than 100 patients are now treated by LVRS on an annual basis. Another study looked at the potential of patients qualifying for lung volume reduction surgery, and this is also based on the STS database. And if you go through this algorithm, you can see that only 15% of the patients with upper lobe predominant disease will qualify for lung volume reduction surgery. And so these are patients both with complete and incomplete fissures, so only 15%. There was a nice invited commentary at the end of this paper by Keith Neuheim saying, indeed, as already discussed, the referral nowadays for a treatment that has been proven to be effective remains infrequent, unfortunately. So let's move to lung transplantation, and I will not show any results on lung volume reduction surgery because in our place we are doing very few patients at the moment, only two or three a year, because we are a little bit biased towards lung transplantation, and I will discuss that. This slide from the International Society for Heart and Lung Transplantation shows the total number of cases of lung transplants across the world. So just above 3,500 patients were transplanted in the year 2010. So very few patients finally get this treatment modality. Nearly 50% of the patients with single lung and 27% of the patients with double lung are transplanted for emphysema. A quick insight in our lung transplant program in Leuven. Until the end of the year 2012, we did 711 transplants, mainly double lung transplants. And as you can see, in our place, 46% of all the transplants are done for patients with emphysema. And I think we can be proud of our results with the 3-year survival of 80%, a 5-year survival of 70%, and a 10-year survival above 50%. What are the guidelines now for patients who qualify for transplantation? They should have irreversible progressive lung disease. being on optimal medical treatment, including oxygen, with no other better surgical treatment available, a limited life expectancy, and we also have an age limit, 65 years. And these are the specific guidelines for patients with emphysema. They have a high Bode index above 7, very low FEV1 and diffusion capacity, or the homogeneous type. In addition, patients are usually hospitalized because of acute hypercapnia or pulmonary hypertension and cor pulmonale despite oxygen therapy. Of course, transplantation is plagued by limitations like donor shortage, primary graft dysfunction, and chronic allograft dysfunction, the development of opportunistic infections, and post-transplant malignancies. We know that, and we have to discuss that with our patients. Looking into the overall survival results, showing here survival in patients both for single lung transplantation and double lung transplantation in green, and you can see that patients after double lung transplantation have superior survival. Is this related to age? No, if you look into the age categories, for both younger and older patients, double lung transplantation carries a survival advantage. Is age important? Yes, if you look at this relative risk of 1-year mortality slide, you can see that the risk for mortality increases above the age of 55. Is there a survival benefit after transplantation? So this is a study on data from UNOS, looking at all the patients that were transplanted for emphysema in the US. And the conclusion of the paper is that it gives indeed a survival benefit in younger patients less than 60 years. Both for single lung transplantation and double lung transplantation, but the survival benefit is better for double lung transplantation patients. And which patient qualifies now for transplantation? There are 3 patients listed here. As you can see, patients with the survival without transplantation, single lung or double lung. This is an older patient, 62 years. Survival is better without transplantation. On the other hand, if you look at this patient, 58 years, but he has pulmonary hypertension, survival will be better both after single lung and double lung transplantation than without transplantation. So this comes to a summary as follows. What is the ideal patient for transplantation? The patient who is less than 60 years, who has single organ failure, no comorbidity, he's very compliant, has good support, and he has long time no smoking history. What is the absolute indication? A patient with a Bode index above 7, who has very low FEV1 and diffusion capacity, homogeneous type, those with hypercapnia, those with cor pulmonale and pulmonary hypertension, and patients with bronchiectasis who will need a double lung transplant. Now, who is the questionable patient? The one who's above 60 years of age, with cumulative comorbidity, who's in a wheelchair, on steroids. That's it. Now, let's put the 2 procedures into perspective. So the main question, in fact, is do we need to repair the lung or do we need to replace the lung? It is already stated in the literature, lung transplantation is the first choice in emphysema patients. And this is a recent publication, it's still in press, whereby survival was compared from the group in Washington, Seattle, between patients who had lung volume resection alone versus those who had lung volume reduction followed by transplantation, and there was no survival difference. However, if you look at patients who had transplantation alone versus those who had volume reduction first and transplantation alone, there was a survival advantage for those patients who got the transplant first. So, who is the high-risk group? Patients with limited life expectancy, we already discussed them. These patients with all the risk factors, they should go for transplantation immediately. Selection criteria between both groups, we already discussed it, those who qualify for volume reduction, those who qualify for transplantation. Both procedures have disadvantages. There is less functional improvement with volume reduction, and only about 15% will match the selection criteria. There are disadvantages for transplantation with waiting time, donor shortage, and the other complications. Volume reduction surgery, however, can be a bridge to transplantation. That has been discussed by the group here at St. Louis, also by the group in Zurich. Also, bronchoscopic lung volume reduction procedure can be a bridge to transplantation, as published by Federico Venuta. Lung transplantation can be prevented in a percentage of patients. It can be delayed by 3 to 4 years so that the patient can be transplanted in a later cohort with all the advantages. And lung transplantation is not compromised by volume reduction surgery. I want to finish by bringing you to the ideal world. The ideal world is that we have shops where we can buy lungs and transplant all our emphysema patients. Of course, we need donors, and as you can see in Belgium, we are on the top with 9.4 lung donors per million population, and that's why we have one of the highest rates of transplantation across Europe, with nearly 12 patients transplanted per million population. And we have done that by extending our donor criteria as listed here, and also by going to the donor hospital at the time of organ offer, and thereby we were able to increase our lung yield to 30 and even 35%, with no real difference in our survival results after transplantation. If there would be tolerance between races, if there would be tolerance between species, then transplantation would be the best choice, I think, for every patient, and we can avoid all the immunosuppression medication. But then endobronchial lung volume reduction came, and there was a fight between surgeons and pulmonologists who would treat the patient best. And now we not only have staples, we also have coils. But I think the best is there should be tolerance between the pulmonologist and the surgeon, and we should discuss every patient in an MDT conference. Here you can see two surgeons discussing what is the best wine, the white wine or the red wine. And you can recognize Federico Venuta and Eugenio Pompeo, but in fact we need a pulmonologist like Palafshah to blind both the surgeons and to do a randomized control crossover blinded study. So in conclusion, lung transplantation is the first choice in country with good donor organ availability. It's an absolute indication in high-risk emphysema patients, and it gives superior results in young patients, both survival, exercise capacity, pulmonary function, and dyspnea score. Lung volume reduction surgery is effective for a small cohort, 15% with heterogeneous upper lobe disease. It's proven to be effective in this group, both survival, exercise, pulmonary function, and dyspnea. However, it has become more and more minimally invasive procedure, and referral for volume reduction remains too infrequent, in my opinion. Thank you very much for your attention.
Any questions, please? Just a question there.
Thank you. Mohammed Hawari from Nottingham. Very interesting talk. I'm going to bring two scenarios together. One scenario is patients we operate on for cancer surgery. They do have lobectomy or pneumonectomy. And we follow them down the line, and the healthy lung tissue will grow up, and they will get better functional reserve, and they can even go back to their normal preoperative lung functions. And another scenario is we in theater, anesthetist having struggled with ventilation, we pinch the pulmonary artery, we reduce the perfusion mismatch, and the ventilation improves and the oxygenation improves. So the question is, if we combine both together, should we start doing anatomical lung volume reduction by targeting the bronchus, the artery, and the vein to the segment, which is the heterogenic segment in the upper lobe? And by this, we sort out the volume issue, we sort out the perfusion mismatch, and at the same time allow the healthy lung tissue to re-expand rather than allow the non-healthy residual lung tissue to re-expand, as is happening at the moment in non-anatomical resections. Thank you.
Yeah. I think I follow you completely. I would also prefer lobectomy in patients with cancer, of course. Well, I'm not clear on that, actually. Certainly in patients with lower lobe disease, papers have shown that a lobectomy can give us good results. But in upper lobe disease, I'm not clear whether we should do lobectomy. I think you will create more air leaks afterwards compared to stapling, in my opinion, because you are working in a very emphysematous lung.
Any more questions? If not, thank you, Dirk.